Hello and welcome to another part of this endocrinology series. My name is Dr. Betty Dube and I'm a certified diabetes educator. This part of the series I'll be covering type 2 diabetes. Here's a captioning statement just to remind you that all the captions that you may use in this video are up to 90% accurate. So the learning objectives for this session are to describe the epidemiology, etiology, and pathophysiology of diabetes mellitus. We'll identify the signs, symptoms, and characteristics of type 2 diabetes. We'll discuss the diagnosis pathway of type 2 diabetes, and then we'll delve into the pharmacotherapy of type 2 diabetes. We'll go through the mode of action, cautions, contraindications, and side effects of the main classes of drugs used to treat type 2 diabetes. And then the next series, I'll cover the macro and microvascular complications of diabetes. We'll also explore and apply evidence-based regarding the management of type 2 diabetes. And this is another part of this series where we delve into different case studies. So just to start, as a recap, just to remind everyone where the pancreas is in the human body and its functions as well. So on top of the production of insulin, it also produces glucagon, also produces vasoactive intestinal peptide, as well as somatostatin. Okay, and just to remind you again, the pancreas has both the exocrine function and an endocrine function. And in this particular series, we will be reviewing the endocrine system part of the pancreas and the hormones associated with this part of the pancreas. So, just to remind you again about that negative feedback mechanism that occurs when to achieve homeostasis, when there's stimulus in the blood in the form of blood glucose. When that goes high, the pancreas produces insulin, and those will be the beta cells in the pancreas. And this then instructs the liver to take up the glucose and store it as glycogen, as well as the body cells take up the glucose. And so the blood in the glucose declines and homeostasis is achieved. And likewise, when you have a stimulus that reduces the blood glucose levels, for example, during a period of starvation or after an exercise, the alpha cells of the pancreas produce glucagon, and that glucagon goes to the liver and breaks down glycogen to release glucose, and then glucose in the blood rises again, and you achieve homeostasis. Just to recap again what diabetes is, so diabetes mellitus is the most common endocrine disorder, and it's a chronic metabolic condition characterized by hyperglycemia, either due to impaired insulin production and secretion with or without insulin resistance. And this causes the impairment of carbohydrate, fat, and protein metabolism also. So just as a reminder, insulin is a hormone produced in the pancreas to regulate glycemic levels in the blood. It is synthesized in the pancreatic beta cells, initially as a polypeptide precursor, pre-proinsulin. It circulates freely as a monomer and has a half-life of 3 to 5 minutes. It is primarily metabolized in the liver and kidneys. Okay, so the interaction of insulin with the receptor on the cell surface sets off a chain of messages within the cell, which opens up transport processes for glucose, amino acids, as well as electrolytes. So an acute deficiency causes uninhibited hepatic glycogenolysis as well as gluconeogenesis, causing an increased hepatic glucose output and decreased glucose uptake, leading to hyperglycemia, high blood glucose levels. So here's again a recap of the classifications of diabetes. Again, there's the different types of diabetes, type 1 and type 3C. There's also gestational diabetes, and there's also different forms of diabetes here. So some of them have been given numbers over the last few years. In this series, we're only covering the main types of diabetes. And for this particular part, I'm covering type 2 diabetes. So the diagnosis of diabetes does have different classifications. So according to the World Health Organization, the fasting blood glucose should be equal to or above 7 millimoles per liter, and a random blood glucose could be equal or above 11.1 millimoles per liter. it is important that you make sure you use the right units when you're interpreting the lab results. NICE also classifies diabetes as persistent hyperglycemia, where the HbA1c is 48 or over, so that's 48 millimoles per mole. That's equivalent to around 6.5% or more, or a fasting blood glucose level of 7 or over, 7 millimoles per liter or over, or a random blood glucose of 11.1 millimole per liter, and also in the presence of other symptoms associated with diabetes. I thought I'd include this here again just to remind you all about the type 2 diabetes mostly, and the what could be symptomatic or asymptomatic. Okay, when it comes to the pathophysiology, usually less acute because relative insulin deficiency decreases over time. So it's not as an acute presentation as type 1 diabetes. The initial response to hyperglycemia is increased insulin production, enabling euglycemia. And this occurs to remember that negative feedback mechanism I just covered. Then hyperinsulinemia can maintain blood glucose levels for a period of time, but as insulin resistance increases, eventually not enough insulin can be produced and the beta cell functions deteriorates, leading to a relative deficiency in insulin and hyperglycemia persists. So if this cycle is not interrupted, type 2 diabetes does develop. And here's just a schematic representation of what I was talking about here. And there are some risks associated with developing type 2 diabetes, but ultimately they all result into that persistent hyperglycemia, and that will be diagnosed as type 2 diabetes in this case. So again, for those visual learners, I thought I would include this here just for you to have a look at the different aspects of the body that could be affected, leading to the pathophysiology of type 2 diabetes. So in the pancreas, you have reduced insulin secretion and also hypergluconemia. Okay, and then in the adipose tissues, you have hyperlipidemia because there's increased circulating fatty acids just because of that, not enough insulin to break those down. And then in the gut, you have impaired incretin effect in the gut. And then in the liver, you have insulin resistance, okay, resulting into increased hepatic glucose output that's worsening the hyperglycemia. And then in the muscle, you could have insulin resistance as well. Okay. So over the years, we've also determined there's some pre-diabetes factors that have been put through, and these ones could be reversed if they're caught earlier, if somebody is diagnosed earlier with this. So impaired glucose tolerance or impaired fasting glucose or hyperinsulinemia may be detected before overt diabetes develops. Thus, a strict diet and exercise regimen leading to weight loss and improved insulin sensitivity may delay or prevent the onset of diabetes if this is caught early. At the time of diagnosis, most have already lost about 50% of the beta cell function. Irrespective of the treatment, beta cell function continues to decline with time and often leading to the need of exogenous insulin therapy, as we covered for type 1 diabetes. There's also another syndrome called metabolic syndrome, which is a group of risk factors that include insulin resistance or glucose intolerance, hyperinsulinemia, hypertension, dyslipidemia, central obesity, and atherosclerosis. Okay, all these are common and can commonly result into the development of type 2 diabetes. Okay, so back to diagnosis again as a reminder, those are the parameters, these will be the symptoms, but importantly, or rather the signs, but importantly, out with the signs, people also present with symptoms, and these are the ones listed here for type 2 diabetes. So you have excessive thirst and dry mouth, frequent and abundant urination, lack of energy or extreme tiredness, blurred vision, and the recurrence of fungal infections. Okay, so worldwide, diabetes is an epidemic, and the prevalence of type 2 diabetes is increasingly rapid even in Scotland. The largest part of the increase is likely due to poor diet, low levels of physical activity, and increased levels of obesity. Okay, And here I've included the risk factors for type 2 diabetes. So there are modifiable and non-modifiable risk factors, just like you covered in the cardiology module. Some of the non-modifiable risk factors include history of gestational diabetes. So if you had diabetes, if somebody had diabetes when they're pregnant, then their risk of developing type 2 diabetes is increased. Race or ethnicity is a risk factor. So mostly people of Asian or Black African origin are at high risk. Age over 45 is a risk factor which you cannot change as well. But alongside this, family history of diabetes does put yourself at risk of developing type 2 diabetes. Now, on the other side, we do have modifiable risk factors for type 2 diabetes, and these include physical inactivity. So in theory, if you increase your activity, you could potentially prevent or delay the progression of type 2 diabetes. There's also high body weight or high body fat as well is a risk factor. High blood pressure is a risk factor, as well as high cholesterol is a risk factor. So all these are things we could modify by diet, exercise. Those could help reduce that progression and reduce our risk factors of developing type 2 diabetes. Okay, so globally, again, the snapshot I used for the other, when I introduced these modules, we have over 500 million living with diabetes. Over 200 million are unaware that they have the condition, and type 2 diabetes accounts for over 90% of the diabetes population, people in the world. And this is driven by urbanization, aging populations, reduced physical activity, and rising obesity. Okay, and it is said that 81% of adults with diabetes live in low and middle income countries. And the future progression is that around 800 million people, so that's 1 in 8 globally, are expected to have diabetes, which will mark around 46% increase. So some awareness gaps trends to be aware of. So more than 4 in 10 people with diabetes are undiagnosed, and preventably type 2 diabetes can be prevented or delayed through lifestyle changes and early diagnosis, as I just mentioned earlier. And this is a burden to the healthcare system, and it does contribute to a significant global health expenditure and complications if unmanaged. Okay, in the UK, again, we have almost 6 million people living with diabetes at an all-time high. Okay, and around 4 people are living without a diagnosis, and the figures are just going higher and higher. And as I said, 90% of the people with diabetes actually have type 2 diabetes, which is a significant number. Okay, just again to remind you what diabetes type 2 present as. So you'll have regularly you have insulin, and homeostasis is achieved when there's sugar. Insulin receptors stick to the insulin, and sugar transporter takes up sugar from the cells, and then so it's reduced from the blood. But when you have diabetes, type 2 diabetes, some insulin is present, but cells cannot respond to it. So there's insulin resistance. That's why the blood sugar rises, and then if you do take medication, that is prevented, so you're able to reduce that high blood glucose levels. Again, this is just a very basic picture representation I thought I would include here. But also in this series, I've embedded some videos from Diabetes UK, and this is one on type 2 diabetes. I'm not sure if I'll be able to play it here. If it doesn't play, then I'll put this link on the Moodle page, and you'll be able to listen to it in your own time. It's just a very simplified version of what type 2 diabetes is. Okay, now I thought I'll delve into the pharmacotherapy of diabetes ourselves as pharmacy professionals. This is something we always are excited about. So there's the timeline of what happened. So we had diabetes treatment in the pre-insulin era. So that's really long time ago, and I think they were treating it in a very different way. There was keto diets, starvation. I think they were seeing that if the person is not given the food that causes the high blood glucose levels, potentially that does prolong their life. But then a breakthrough came through when we have in the 1940s, that was the insulins. I think I covered this in type 1 diabetes, but I want to go through the oral therapies mostly in 1956, when you have the first sulfonylurea that came in the market. Tolbutamide came in 1957, and then in 1967 57 rather, we had metformin. So that was quite significant in the treatment of type 2 diabetes. Then we have other drugs that came through the market there. I thought I'll just put everything here for completion. But of course, in the 2000s, we had significant breakthrough. Again, like from 2000 and onwards, we had 2006 rather, we have the incretin, the DPP4 inhibitors, which all covers. And then from 2010 onwards, we have the GLP-1, which have significantly changed the landscape in the treatment of type 2 diabetes, but also obesity, as we all have heard about. And then from 2013 onwards, we have the SGLT2 inhibitors. These are all listed here. So we have the gliptins, we have the gliflozins, we have the glutides, and I'll be covering those. So presently, if some of you are aware, we do have the cardiovascular outcome trials that must be completed for any diabetic medications before they come into the market. And these are some of the landmark trials listed here for the DPP4s, for the SGLT2s, and for the GLP-1s as well, receptor agonists. The trials I've had a look at, and I'll also encourage that you have a look at also. But the promise of diabetes prevention all through has been lifestyle changes. Okay, and then on top of that, the medications as well. Okay, and then in the 2000s, we've actually been able, some people have been able to achieve remission with type 2 diabetes, and there are some trials that allude to that. And then technology advancement has also captured a few other treatment options there, but also some advancements like insulin pumps and continuous glucose monitoring has significantly changed the landscape of diabetes management. In the future, we're looking at precision medicine and artificial intelligence to guide us better, but there's also some trials that are showing promising with pancreatic transplantation. So this is the near future, and this is ongoing work. And I thought I would include all this here for completion. Okay, so I'd want to now summarize the pharmacotherapy for type 2 diabetes. So we'll be going through the mode of action, the doses, the side effects, the interactions, the contraindications, cautions, and potentially a monitoring required for each of the agents. And all these can be found in the specific product, summary of product characteristics. And here is a snapshot of all the agents. I really like this particular representation here. I think it shows us just how aware everything works in one page, if you like. So medications to reduce hyperglycemia. So as you know, the treatment of insulin, of type 1 diabetes rather, is insulin, but for type 2 diabetes we have all these options here, which is quite exciting in the pharmacy world. So we have insulin secretion can be increased by sulfonylureas, the meglitinides, and incretin mimetics, which I'll be covering shortly. And then there's some that reduce glucagon secretion, and these again are the insulin, incretin mimetics, and a drug called amylin. And then, so they show you also where they work. And then appetite control, this is done by the incretin mimetics, and this is a side effect, or rather a mode of action that has been captured, resulting into weight loss as well. And then there's glucose metabolism in the liver, and this is done by the GLT2 drugs. And then we have glucose uptake and utilization in the cells. A drug like metformin does that, so does pioglitazone. Then we have reduces lipotoxicity. Pioglitazone does this as well. And then there's a reduction in hepatic glucose output. Metformin tends to do this as well as pioglitazone. And then also there's a reduction in gastrointestinal absorption, and incretin mimetics do this, so do the alpha glucosidase inhibitors. So now let's delve into each of these chemicals. So the main classes of oral medication are the sulfonylurea. So we have glipizide, glyburide, glyclazide, and glimepiride. And then we have the meglitinides, so ripaglinide and nateglinide. Then we have the guanides, and in this case, we only have metformin in the market just now. And then we have the thiazolidinediones, diones like pioglitazone is the only one left in the market. If some of you might be aware that rosiglitazone Actros was also in the market at some point, but was withdrawn due to cardiovascular increase of cardiovascular events, and this is what made it compulsory for drug manufacturers to complete the cardiovascular outcome trials prior to any diabetic-related drug being authorized. Okay, and then we have the alpha glucosidase inhibitors such as acarbose. I think that's the only one we have in the market in the UK. Well, then we have the DPP4 inhibitors such as the GLP. These are the gliptins such as sitagliptin. And then we have the SGLT2 inhibitors such as DAPA, CANA, EMPA, and etogliflozin, so the flozins. Okay, now we'll delve into each of these classes. First, we'll start with the biguanides, and this is really metformin is the only one in this categories. What does it do? It increases hepatic adenosine monophosphate activated protein kinase activity, thus reducing hepatic gluconeogenesis and lipogenesis, and increases insulin-mediated uptake of glucose in the muscle. So it's a dual function. Metformin is the only one in this class. It's the initial drug of choice for most people who are diagnosed with type 2 diabetes, unless otherwise contraindicated, as we'll review when we go into the NICE guideline. So normally the initial dose will be 500 milligrams once a day for a week, and then that will be increased gradually to a maximum of 2 grams per day. Most of the most common side effect of metformin is GI related side effects, which could range, diarrhea could range between 12 to 50%, nausea and vomiting up to 26%. Some people do experience flatulence up to 10%. Some may experience headache, chills, dizziness, taste disorder, and all these others listed here. Again, remember some of these are really rare side effects, but I think like in the elderly, something like a vitamin B12 deficiency is something that has to be monitored closely. Okay, when it comes to contraindications, of course, if you have hypersensitivity to the drug, then you would not be a candidate for it. And if you have severe renal dysfunctions with a EGFR of less than 30, will not be a candidate to initiate it. Okay. Interactions, please have a look at the BNF for these. There are many that are listed there. Monitoring when somebody is on metformin, in this case, would be the red blood cell and hemoglobin count, just because of that potential vitamin B12 deficiency. And then also renal function should be initially monitored and then analyzed every year. Okay, and if the AGFR is lower than the normal, then it should be repeated more frequently here. Also, in some practices, they do review the vitamin B12 and folate levels. Also, megaloblastic anemia must be ruled out. Okay. When we move on now to the sulfonylureas, these act by binding to the ATP-sensitive potassium channels, or KATP channels, in the beta cells of the pancreas, which leads to inhibition of those channels and alters the resting membrane potential of the cell, causing an influx of calcium and stimulation of insulin secretion. As you can see, you need some insulin for this to act. So they are orally taken, and there are different ones. They are listed before. I just left it here for you to then have a quick think which drug is a sulfonylurea. I think you all know which ones those are. Here are some listed common side effects. Again, very, very low. And the dosing varies by different agents, and please have a look at the BNF. Importantly for this class of drugs, as the name says, it's a sulfonylurea, and hypersensitivity to a drug. Somebody with a sulfur allergy can potentially be allergic to this drug. So it's always important to be mindful when this is being initiated for anyone with a reported and confirmed sulfur allergy. And this is down to the chemical structure of the drug. Interactions, again, they do cause hypoglycemia, and they will interact with other drugs that cause hypoglycemia. So please have a look at the BNF. Monitoring for this is hypoglycemia is important. That presents, as you remember, fatigue, excessive hunger, numbness. Okay, also can cause a bit of weight fluctuation, but can also cause weight gain in most people. Okay, and then we move on to the thiazolidinediones. Okay, and these activate the peroxisome proliferator activated receptor, gamma, so PPAR gamma, a nuclear receptor, which increases insulin sensitivity and resultant peripheral uptake of glucose and increases the level of adiponectin, a fat tissue secreted cytokinin that increases both the insulin sensitive adipocytes and stimulates fatty acid oxidation. And in this class, we have pioglitazone only in the market. And again, it's no longer initiated as an initial drug, and you'll see when we look at the guidelines there. But many people who are stabilized on it are still on it. In my practice, I've probably had always a handful of people in maybe who were still on pioglitazone, the only one in the market. Here are the listed side effects, and it does also cause hypoglycemia, and these other listed here. Again, contraindications would be if somebody has hypersensitivity, but importantly here, if somebody does present with heart failure, it will not be the best drug of choice for them, and it's also contraindicated in pregnancy. For interactions, please have a look at the BNF, but also it will interact with other drugs that cause hypoglycemia. Monitoring for this, liver function tests are important at initiation. Also, somebody should be reviewed for signs of or symptoms of heart failure, and also does cause a bit of weight gain. So again, you can probably see that it will not be the best drug for somebody who is overweight, for example. Okay, and then we'll move on to the alpha glucosidase inhibitors, and these act by competitively inhibiting alpha glucosidase enzymes in the intestinal brush border cells that digest the dietary starch, thus inhibiting the polysaccharide reabsorption and the metabolism of sucrose to glucose and fructose. So they act in the gut. Okay, acarbose is the one in this class, and we do start with a lower dose of it, and it's normally taken up to 3 times a day before meals. Importantly here, the main side effects which then reduced its use over time is the flatulence, which is up to 70%, just because of its mode of action, as I just told you about there. But this does tend to decrease with time, so most people end up tolerating it if it's a drug they've been put on and they're tolerating it to continue with. Diarrhea is also common, and other GI side effects as listed here. With regards to, again, to contraindications, if somebody has hypersensitivity to the drug, they would not be taking it, but also anyone with any GI conditions, this will not be the best drug for them. Monitoring, again, would be a liver function test for this one, at least every 3 months for the first year. Okay. And acarbose is the drug in this class of drugs. Next, we'll move on to the flozin. So these inhibit the sodium glucose co-transporter 2, so the SGLT2, in the proximal tubules of the renal glomeruli, causing inhibition of 90% glucose resorption and resulting in glycosuria in people with diabetes, which in turn lowers the plasma glucose level, so it acts in the kidney. You must have covered this when you covered the cardiovascular module and the heart failure. So again, depending on the product, the flozins, the initial dose will be as per indicated in the BNF. Okay. When it comes to side effects, these are listed here again. One we normally mention is the frequent UTIs, just because it does increase the sugar content in the urine, and this makes the people on it prone to UTIs. So it's important that the people keep hydrated. Again, interactions, check the BNF, and contraindications will be hypersensitivity to the drug, but also end-stage renal disease will be contraindicated, and it's also contraindicated in patients on dialysis, just because it does enact its function in the liver, rather in the kidney rather not the liver. Monitoring, importantly, is renal function at baseline and periodically during treatment, and as well as cholesterol levels. Okay. Now we'll move on to the meglitinides. They exert their effects via different pancreatic beta cell receptors, but they act similarly to sulfonylureas by regulating the ATP-sensitive potassium channels in the pancreatic beta cells, thereby causing an increase in insulin secretion. Again, they'll only be effective if there is some insulin to work with. These are taken with meals 2 or 3 times a day. An example here. There are very few of them in the market just now. Okay, Again, they do cause hypoglycemia. Up to a third of the patients who might experience hypoglycemia, but also they do cause weight gain. Again, they will not be the best choice for somebody who's overweight. Contraindications, anyone with ketoacidosis, that will be contraindicated, and they do interact with any other drugs that could cause hypoglycemia. Also have a look at the BNF for other contraindications and interactions. Monitoring for these ones will be the liver and renal function. Okay, I thought I'll go back and revisit the glucose homeostasis again. Remember, it's complex, an interplay of several hormones. Insulin, amylin are produced in the pancreatic beta cells, glucagon produced in the pancreatic alpha cells, and then you have the GI peptides, including glucagon-like peptide 1, so GLP-1, and glucose-dependent insulinotropic polypeptide GIP. Okay. Then we have incretin mimetics, and these are the GLP-1 and the GIP, are called incretin hormones that link the absorption of nutrients from the GIT with pancreatic hormone secretion. These are released in the setting of a meal after the digestion and absorption of glucose, protein, and fat, and provide one of the physiologic connections between eating and insulin release. Abnormal regulation of these peptides may contribute to the development of diabetes. So that's important. I thought I'll revisit this so that you understand as I move on with the mode of action, all the other pharmacotherapy options we have for type 2 diabetes. Why? What is their place in that whole homeostasis? We've seen the other ones, how they impact on insulin production in a way, but these ones have gone out with the insulin part of diabetes. First, these are all under the umbrella incretin mimetics because they bind to and activate glucagon-like peptide, so that's GLP-1 receptors, hence increasing insulin secretion, suppressing glucagon secretion, increasing satiety, and slowing gastric emptying. Okay, all these effects help lower blood glucose. And again, here's a just a diagrammatic representation of all the words I've just been saying, in case you wondered if it became too much. So look at there, oral glucose is taken. When it gets to the small intestine is where the incretins act. You see there the different ones, how they can potentially result into insulin being produced. Okay, or rather less blood glucose overall. Okay, we'll move on. Okay, so first are the gliptins. So they inhibit the enzyme dipeptidyl peptidase 4, so DPP4, that's where the name comes from. This deactivates glucose-dependent insulinotropic polypeptide, GIP, and glucagon-like peptide 1, GLP-1, among others. These influence glucose control via multiple effects such as decreasing glucagon release and increasing glucose-dependent insulin release, decreasing gastric emptying, and satiety increasing. Most of them are taken once daily, okay? And there are a few of them in the market for you to have a look. Okay, and that's how they act, and that's where the name came from. Okay. So examples here, we have sitagliptin, to name one of them. Importantly, the side effects, they do cause hypoglycemia as well, and they do increase the risk of having urinary tract infections. And for some reason, so pharyngitis is also listed as a side effect, and in some cases, they may cause acute pancreatitis. You must check the individual monographs for the specific side effects and their frequency. Interactions, again, they do cause hypoglycemia, so they would interact with other drugs causing hypoglycemia. And please have a look at the BNF for these specific ones. When it comes to contraindications, so linagliptin does not need any dose adjustment in renal failure. So that's important if somebody has renal disease, that linagliptin would be a choice if the gliptins are the ones that are to be used, and others have to be adjusted based on the person's EGFR. Okay. Monitoring will be mostly renal function for these ones, but also have a look at the SPC for these products. Okay. I thought I'd include this here. I think, again, myself as a visual learner, I very benefit much from these schematic representations of modes of action. So when you take a DPP4 inhibitor, so it does extend the half-life of the endogenous incretins GLP-1 and GIP. So you have increased insulin secretion, beg your pardon, and decreased glucagon secretion. And these, in turn, you have a reduction in the HbA1c and overall hypoglycemia. Okay, and then when we go back again to visit the glucagon-like peptide 1 GLP agonist, so the GLP-1 is produced from the proglucagon gene in L cells of the small intestine. It binds to a specific GLP-1 receptor, which is expressed in various tissues, including pancreatic beta cells, pancreatic ducts, gastric mucosa, kidney, lung, and all these other tissues here. Okay. I wanted to mention this multi-hormonal glucose regulation aspect of the GLP-1s. And this is, again, just a pictorial representation of the GLP-1 as small compounds that we have that only till recently has been further investigated as an option for pharmacotherapy. Okay, so what do they do as medication? So they are incretin mimetics that bind to and activate the glucagon-like peptide 1 receptors, hence increasing insulin secretion, suppressing glucagon secretion, increasing satiety, and slowing gastric emptying. All these effects help lower blood glucose levels. Most of these are injectables, but we do have one oral, which is the semaglutide. Examples will be the semaglutide, will be the semaglutide is the one that comes to mind. We have liraglutide as well. Okay, so pharmacokinetics of these, the analogs have a longer duration of action than the endogenous GLP-1, and that's how they were able to be captured as therapeutic agents. The common side effect, most common one, is nausea and other GI disturbances. And their role in therapy, they are added on as third-line therapy for patients whose BMI above 35 kilograms per meter squared. Efficacy, the treatment should only be continued if there has been at least an HbA1c reduction of at least 1%, or actually not all, and a weight loss of at least 3% from the starting treatment over a period of 6 months. So this is what will justify continuation of treatment. If both of these have not occurred over 6 months, then probably this patient is not a candidate for these agents. Okay, so I'll move on to tirzepatide, one of the newer agents in this pharmacotherapy space. And it has a dual action, which is quite exciting. So it's a long-acting GIP. So it's a long-acting glucose-dependent insulinotropic polypeptide receptor, and the GLP-1 glucagon-like peptide 1 receptor agonist that increases insulin sensitivity and secretion. It also suppresses glucagon secretion and slows gastric emptying. The only product we have in the market just now is the one that's been marketed as Mounjaro. So it's a once weekly injection. And then you start with a low dose, and after 4 weeks, the dose should be increased, okay, depending on our tolerability. I thought I'd include this placing therapy here from the NICE T8924. So according to the NICE guideline, it is an alternative to GLP-1 receptor agonist. So for treating type 2 diabetes alongside diet and exercise in adults who are insufficiently controlled, only if, so this is the factors here. Triple therapy with metformin and 2 other oral antidiabetic drugs is ineffective, not tolerated, or contraindicated, and they have a body mass index of 35 kilograms per meter squared or more, and specific physiological, psychological, and other medical problems associated with obesity. So this is because if somebody has a BMI of 35, they're potentially obese. Okay. Thought I'd include this here. Oh, this went too fast. So So revisit that slide again. But I thought I would capture this slide here from Eli Lilly, who are the manufacturers of our Mounjaro as we know it. So this is the tirzepatide, and this is a comprehensive set of mode of action studies in patients with or without diabetes. And in this case, they were doing it more for the weight loss action of it. But I thought I'd include this here and all the landmark trials that they have put through, and all the studies that are ongoing. I think most of these are probably almost completed now. This is from 2021, but just for you to have to see that for the ones people with type 2 diabetes, they looked at tirzepatide versus placebo, and of course we did see that it was more effective. It's also more effective than the raglutide, but importantly, there's this one here that was head to head with, so it's Wegovy, which is the trade name for semaglutide, and tirzepatide, which is Mounjaro. They evaluated the effect on the alpha and beta cell function, insulin sensitivity, and energy balance. So this was important. Okay. So all these were the submissions they included for them to get marketing authorization for type 2 diabetes. Okay. So I'll continue here with its place in therapy overall. So in the UK, this is where it would stand. So when insulin, so if somebody has a BMI of less than 35, and insulin therapy would have significant occupational implications. So if they were type 2 diabetic patients with low BMI, that's less than 35, but if they started on insulin, they would have some work-related implications, then they would be a candidate for this drug, or weight loss would benefit other significant obesity-related complications. So this has been reserved. Just to note here that lower BMI thresholds, usually reduced by 2.5 kilograms per meter squared, should be used for people of South Asian, Chinese, or other Asian, Middle Eastern, Black, African, Caribbean family backgrounds. So that's important. And they can be initiated by the diabetes specialist team or GP diabetes specialist. Okay. Efficacy treatment should only be continued if there has been at least a 1% HbA1c reduction, or at least a 3% weight loss over a 6 months period. Okay, so at each review, compliance must be monitored, injection technique must be monitored, and also any side effects that would occur. I've included these references, these links for you to review in your own time. I thought I'd also include the evidence. So just on the paper that was published in 2024 about how tirzepatide is a novel antidiabetic molecule that unfolded dual action. So as I've just explained, it does have an effect on the GLP-1 as well as the GIP. So that's important. So theoretically speaking, it would be more effective than another agent that only has mono mode of action. Okay, so when it comes to insulin therapy in type 2 diabetes, so the young age of onset and tighter glycemic targets mean that the majority of patients progress into insulin therapy. It's just how the presentation is the last few years now. So evidence confirms that long-term glycemic improvement reduces the risk of both micro and macro diabetic-related complications. Insulin is introduced to an oral medication schedule, and the oral medication may be reduced or stopped. So it depends. Every patient is different. The most common regimen is a once daily basal insulin, and that will be the best one. There could also be a twice daily biphasic, and we could also have the prandial insulin, as we discussed in the type 1 diabetes section of my series. Studies suggest that patients who have basal insulin or prandial insulin added to the oral therapy have better HbA1c control than those that receive the biphasic insulin. So it will be natural to only see people with type 2 diabetes being initiated on the basal insulin. Okay, so basal insulin regimen is associated with fewer hypoglycemic episodes and less weight gain. And basal insulin should be titrated to achieve normal fasting glucose levels, and put patient taught on self-titration protocol. Okay, in lean patients whose BMI is less than 25 kilograms per meter squared, significant insulin deficiency is likely, so insulin treatment with either basal bolus or twice daily regimen is preferred for these patients. Okay, I thought I would include here the recommended approach for glucose lowering medication selection in type 2 diabetes. Again, for rescue therapy, For symptomatic hyperglycemia, consider insulin and a sulfonylurea and review use when the blood glucose control has been achieved. So this is again when you have if you need rescue therapy. So first line for most people is metformin, as you can see here. And we always have to assess the HbA1c, the cardiovascular risk, as well as the kidney function. Okay, so metformin when somebody has not a high risk cardiovascular risk. Here, metformin will be the agent of choice, and then if it's contraindicated, then the other choices are listed here. As I said, metformin will be the gold standard like the start, but it could be contraindicated for various reasons. And if it is contraindicated, so you could consider DPP4, you can consider the like a drug like pioglitazone, you could also consider a sulfonylurea like glycoside, or you could consider the SGLT2s. So this could be an initiation for some people. So take a few moments to have a look at this particular slide, and I will upload the PDF version for you to review in your own time. But you can see if you have a look here, there's a consideration for insulin therapy and the GLP-1 agents as well, and as triple therapy for the most part. Okay, so I thought I'll quickly revisit sick day rules. I know you've covered this in the cardiovascular module, but dehydration can be a significant risk of when patients taking medications, particularly during acute illness. So if they do experience flu or nausea, vomiting, diarrhea, all these together with existing medical conditions like diabetes, the dehydration does put them at risk of acute kidney injury. Okay, and this can just be reduced by sick day rules for certain medications. Okay, so these common medications can be paused or stopped during the illness. So these are called the sick days, and they can reach that to prevent this dehydration from occurring. And we're using the mnemonic SADMANS. I think you've seen this already. But I'll include it here for completion. And we have this in Scotland, we do have this medicines sick day rules listed here. So the sulfonylureas is the first S. Then we have the ACE inhibitors as the second, the A. The D is for diuretics and direct renin inhibitors. The M is for metformin. The A here is for the ARBs, so the angiotensin receptor blockers, the second A, and then the N is for non-steroidal anti-inflammatories. Then we have the S for the SGLT2 inhibitors, the flozin. So this is important. So you can see here we have sulfonylureas, we have metformin, as well as the third S. They're all diabetic-related medications. So it's important that sick day rules are communicated to every patient who is on these medications. Okay, then we'll move on to special circumstances or patient groups. So the patients on the continuous subcutaneous insulin infusion, this will be a special circumstance that will require special monitoring. We have patients who are pregnant, including patients in labor, they will require special kind of treatment. We have patients undergoing enteral feeding following an incident like a stroke. We also have patients on steroids. This could impair the glucose levels. But importantly, I wanted to mention is fasting patients, for example, during Ramadan. So there is a link here to this special patient group in training and support resource you can have a look at. Okay, so I'll delve into Ramadan. So Ramadan does vary, the dates vary every year, and sometimes it's earlier during the year and sometimes it's later. But please watch this YouTube video and have a look at the summary for the best way to support our patients when they're going through the Ramadan period of the year. Okay, I thought I'll also include here, there's a whole very good resource about Ramadan and diabetes here. Okay, and have a look. And there's also a resource for a fact sheet that's free and is available in different languages there. So as ourselves, for those of us who are in community pharmacy, we are probably the people who are best suited to be providing this information to our patients. Okay, so just to summarize, so type 2 diabetes pharmacotherapy, as you can see here, all these are differently to support to ultimately reduce that hyperglycemia that presents in type 2 diabetes. All of them are listed here, and I thought this is a really a good representation of all the parts of the body where the drugs work, as I've just mentioned. Please take a pause the video and have a quick look at this schematic representation Okay. Again, another recap in diabetes, in not a healthy pancreas, you have glucose coming, insulin works accordingly, and the glucose is taken out of the blood into the muscles or into the liver for storage. But in type 1 diabetes, you have no insulin, so you have glucose in the blood. And in type 2 diabetes, you have some form of insulin, but it's not enough, and there's insulin resistance. So you have some blood glucose in the blood causing the persistent hyperglycemia. Okay, again to recap, the symptoms of diabetes. Again, have a little pause here to have a look at these symptoms of diabetes that you should be aware of. Okay, and then another summary again of the two types of diabetes. Okay, type 1 and type 2, what happens in each of them. Okay. Next in the series, we'll be covering the major complications of diabetes. These include microvascular and macrovascular complications. And here the references are used. Again, if you want to have a look at these, you can refer to the slides that will be loaded on the Moodle page. And importantly, if you have any questions, please post them on the Moodle discussion forum. Thank you for listening.